Good morning. Thank you for joining us. My name is Edgar Gonzalez, and I'm the Assistant Vice President of Development at the OHSU Foundation. On behalf of the Foundation team, we are honored to present today's discussion, Emerging Infectious Diseases, Preparing for the Next Pandemic, featuring Dr. Donna Hansel, Chair of Pathology at OHSU, and Dr. Daniel Streblow, Professor at the Vaccine and Gene Therapy Institute at OHSU. Today we're going to be discussing a multi-pronged approach that OHSU is taking to combat COVID-19 and how we can prepare for the next pandemic that hits our community. Before we begin our conversation with Drs. Hansel and Streblow, I'm quickly going to go through some housekeeping items and how you can engage with us. We will be using a chat function which can be found to the right of your screen. In order to participate in the chat, you can log in via your Vimeo or Facebook accounts or participate as the chat box guest by selecting Chat as Guest in the blue link. If you need assistance at any time during this live stream presentation, email fdnevents@ohsu.edu. We're going to copy that into the chat box now for your reference. Please note this presentation will be recorded and will be available for viewing at the OHSU Foundation website at a later date. We will email a link to the video once the recording is available. And with that, it is my great privilege to open our panel conversation today with Drs. Hansel and Streblow. Let's start off by having you tell us a little bit about yourselves and how you ended up at OHSU. Dr. Hansel?
Of course. First of all, thank you so much to Edgar and the Foundation for putting this together. We are thrilled to be able to tell our stories and to have the audience get to know us a little bit better and everything that's been happening behind the scenes at OHSU. As Edgar mentioned earlier, I'm Chair of Pathology and Laboratory Medicine at OHSU. I guess as a bit of a background, I did my MD and PhD at Johns Hopkins. I'm actually what they call a lifer, so I technically did undergraduate, MD, PhD, residency, and fellowship. A little bit of postdoctoral training there that I split with Erasmus University in the Netherlands. I moved on from Johns Hopkins to the Cleveland Clinic when I was an assistant professor. And after about 7 years in Cleveland, moved to University of California at San Diego as a division chief in anatomic pathology. And just about a year and a half ago, moved to OHSU as chair of pathology. I will say it's been quite a first year on the job with COVID, but we're really excited to be here and looking forward to telling our stories.
Thank you. Dr. Streblow?
Hi, my name is Dan Streblow, and again, I want to thank Edgar for inviting me to come talk to you today, and I want to thank the Foundation for putting this on. My background, I was an undergraduate at the University of Wisconsin-Madison, where I got my degree in pharmacology and toxicology. And then I stayed there, kind of like Donna, and did my PhD in viral pathogenesis, and I worked on HIV. I then came to OHSU as a postdoctoral fellow in the laboratory of Jay Nelson. And I chose OHSU because it really offered a wonderful opportunity for me to grow and learn more about viral pathogenesis and also expand into other viruses, including cytomegalovirus. I was given the opportunity to start a lab at the West Campus, and there my lab focuses on emerging viral diseases, including chikungunya virus, Zika virus, and a number of other alpha viruses that have the potential to reemerge and emerge and cause human disease. And again, thank you for this opportunity, and I look forward to answering any questions that you might have today.
As you can see, we have quite an accomplished duo, and we're excited for this conversation, so let's jump right in. First, Dr. Hansel, we know that OHSU has been a leader in COVID testing in the state of Oregon. Can you tell us a little bit about how the testing got started?
Of course. So as I mentioned earlier, I moved here about maybe a year and a half ago, approximately from Southern California. And you know, one of the big draws for me coming to OHSU was our ability to really represent academic medicine in the state of Oregon. And as the only academic center in the state, this was really an opportunity to develop a program and a department that could give back to the citizens of the state of Oregon. And to me, that was a really big draw in coming here. I didn't expect that there would be a pandemic that would make that dream a reality during the first year. But I'm really appreciative of the opportunity to share with the audience what we've done. So one of the major initiatives when I arrived here in April of 2019 was to build out a microbiology lab section. And that may not seem very glamorous to people in the audience right now, but it's so important. So over the past 25 years or so, OHSU has really had a rudimentary microbiology lab program. Despite the fact that we have these incredible strengths in virology and infectious diseases, fungal disease, bacterial research, human immunology at the institution. And while there have been many efforts to rebuild microbiology over these past 25 years, the challenge really was in the funding. There was not enough funding to build out the infrastructure, to equip the lab, to hire the staff, et cetera. And last year after I arrived, I organized a very high-level meeting with leaders at the institution on both the School of Medicine and the hospital side to say that, you know, we really need this microbiology lab. It would be really almost impossible, we felt, to respond to any kind of emerging infection that would arise. And, you know, we discussed quite a bit that, you know, in addition to kind of short-term effects of infectious diseases, that there was really a long-term risk to human health with emerging pathogens. And, you know, we know from a study that was recently published that it seems that by the year 2050, infectious diseases were likely to kill more people than cancer in the United States alone. And, you know, at this very high-level meeting, we all agreed that this was a really important initiative. We identified new space to place a clinical and research microbiology activities. We applied for grant funding to support infrastructure needs, and we continued on our plan to recruit a microbiology director. We actually have an offer out now, so I'm really excited about that. But you know, that being said, there were so many fiscal challenges around getting this lab up and running. And we were in the middle of working on a larger scale plan when COVID-19 happened. And you know, while fortuitous for our program and our initiative, it's obviously been a tragedy for many people in the US and around the world. And you know, this was really the scenario I was most worried about when I came here last year without having a microbiology lab. And I'll tell you, when I first received the news that COVID-19 was detected in the state, I was out to dinner with my family. It was February 28th. I remember it vividly. We had been talking about how worried we are that COVID-19 could strike our community. And I remember sitting in the restaurant with all these people around, getting ready to go to a Harry Potter show, sitting in close proximity to all of these families around us. And I got the text. And the text came from the school board, and it said that essentially an employee of Forest Hills Elementary School had tested positive. And not only was I worried as a parent and a citizen in the community, but you know, I was really worried as the chair of pathology who ran a laboratory that didn't have a very strong microbiology presence. And so I will tell you, that night, I didn't see much of Harry Potter. And you know, we basically spent the next weeks trying to put together a program. And you know, the night that this notice happened, we started working right away. I stepped out of the show to make a number of phone calls. I had to cancel a trip to our national meeting I had that was scheduled for the following morning. I spent hours discussing the next steps with hospital leadership and administration. And I think probably most importantly, I spent many hours speaking with my associate clinical lab director, Dr. Guang Fan, about the fact that we were not going to let the absence of a microbiology lab in any way stop us from doing what we felt was the right thing for the citizens of Oregon. We needed to get this lab up, and so be it, we had to do it from scratch. And so for our pathology department, the next weeks were just incredibly busy. Dr. Fan and I worked nonstop. We explored every option that was available. Around the state, every place was scrambling. There were not enough testing kits available for our state from the CDC, and I think many states would probably say the same things. The commercial labs were already struggling to meet demand. Manufacturers couldn't keep up with kits. So we realized, as the only academic medical center in the state, we really needed to bring up the testing ourselves, and we did it. At the beginning, we worked with the Oregon Health Authority and the Vaccine and Gene Therapy Institute at OHSU to develop an in-house PCR, this polymerase chain reaction, for COVID-19. Dan Streblow was incredibly helpful, and the VGTI was incredibly helpful in partnering with us to do this. And, you know, we had so much support from senior leadership to get a new lab facility put together where we could securely do the test. I've never had anything happen so quickly, but within 24 hours, we were assigned over 2,000 square feet of laboratory space, and facilities built it out in 3 days. I've never seen anything happen that quickly at any medical institution I've been at. Faculty such as Dan Streblow came over from VGTI to work with myself and Dr. Fan to get the laboratory up and running and make sure the tests were as accurate as possible. And we had over 800 people volunteer to help perform the testing. We basically did whatever it took to get the equipment, to get the lab equipped in 2 weeks. And by late March, we were up and running. At the beginning, we did 250 tests a day. We turned them around in 24 to 48 hours. And this was already the start of the delays for the commercial labs. They were already running 5 to 7 days, even early on in the pandemic. So I would say our ability to stand up this lab made a huge difference, not only for patients, but everyone in the community who needed testing. And I'll tell you, as not a shameless plug, but philanthropy played a huge role in allowing us to continuously expand this lab. The OHSU COVID Response Fund, which raised over $12 million, really was instrumental in helping us bridge some of these major gaps we had and get the testing up and running.
It's fascinating how quickly it all had to come together, but thank you. Dr. Streblow, what was it like to sort of come over from VGTI and do something that was maybe not something you were doing every day and moving into the clinical world? And how did your virology background help you in this?
Yeah, thanks, Edgar. I just want to say that really throughout my scientific lifetime, this has definitely been the most important thing that I've ever done to help the people of Oregon and OHSU get this started. It really sends shivers up my spine to this day that we were able to turn around this quickly. So my background was in virology. And at the Vaccine Gene Therapy, we often work in large groups in order to really attack problems and solve problems and really work on them to the best of our abilities. We often utilize each other's strengths, and we play off these strengths in order to maximize the ability to be successful. So we took the same approach when we were moving into the clinical arena to develop a clinical diagnostic lab for COVID. And as I mentioned, my lab works on emerging viruses, so we're really good at detecting viruses. And it was a natural fit for us to come and establish the assays detecting the virus and antibodies as well against the virus. Working with Dr. Fan and Dr. Hansel were incredible, but there were a lot of other people that were involved in this process. So getting this lab up in 2 weeks was heroic. We really couldn't thank the people who gave money to this enough. We can also thank the OHSU leadership community in helping us and really kind of solidifying everything that we needed in order to make it happen as quickly as possible.
Thank you, Dr. Streblow. Dr. Hansel, tell us a little bit about the different types of tests. You mentioned PCR tests, there's antibody tests. Tell us a little bit about all the different types of tests that exist.
Yeah, that's a great question, and I'll tell you, I think we're starting to see changes on a daily basis. But let me start by talking about the two main types of tests that we have that people probably have heard the most about. So the first test is the PCR test, or polymerase chain reaction test. This is the type of test where you show up and they take a swab and they go very, very deep in your nose. That test is really important because it tells us who has an active infection. And so people who test positive can be isolated and contact tracing can be initiated. This is the test we've really been hearing the most about throughout the US when we talk about shortages, et cetera. The second major test that the audience probably has heard a lot about is the antibody test. And this is a blood-based test. There's been a lot of issues with this test in the past, and at Q&A we could go into more detail with it. But essentially, if the antibody test is done properly, it tells you if you've likely had COVID-19 infection in the past. But that being said, there's a lot of challenges with this test. So early on, there were a number of challenges around what we call specificity, meaning do the tests actually detect COVID-19 or are they cross-reacting with something else? I would say for the most part, some of those early failures have been worked through, and most of the places who are running antibody tests now have really good specificity. The other problem with these tests, though, the antibody tests, is that we're really trying to figure out what they're best used for. You know, one study that just came out showed that antibodies last maybe 6 to 8 weeks at most. And we still don't know, even if you have those antibodies, if they protect you in the future. But, you know, while those studies are going on, and we really need to do longitudinal studies and follow individual patients over time to see what the antibodies mean, we do know that there's probably a good use for them in the setting of plasma donation and potentially after vaccination once we have vaccines more widely available. At OHSU, we run both the PCR test and the antibody test in the lab. Focusing primarily on the PCR test, since this is our high throughput test, I wanted to focus on that for this discussion. As I mentioned earlier, we started off doing about 250 tests a day. Today we do 1,100 to 1,300 tests a day, and we're planning to scale up to be able to do probably several thousand per day in the next month. You know, as part of being able to do this, we're building a bigger lab. And, you know, we're really working with the hospital to continue to build this story of teamwork, collaboration, and funding streams to really help sponsor this effort. As, you know, as we move into the Q&A part of this, we can discuss some of the newer tests that are emerging. So many of those of you in the audience may have heard about a rapid antigen test that the FDA just approved. We're also working on something similar here that we could discuss in more detail. But you know, for now, we can focus on the PCR and the antibody tests. And with that, I'll turn it back to Edgar.
Thank you. It's amazing how quickly you were able to grow from 250 to thousands of tests a day, and we're eager to see how many more we could do so we can truly serve the whole state. Dr. Streblow, we've heard a lot about COVID being a coronavirus, and a coronavirus also being a common cold. So can you tell us a little bit how this one is different from other coronaviruses, especially in the amount of disease that it produces in humans? And can you give us some background on what coronaviruses are and how they differ?
So I'll start with the background. So coronaviruses are a large group of single-stranded RNA viruses that are primarily transmitted through respiratory droplets in direct contact with infected surfaces. There are 7 coronaviruses that infect humans, and these include SARS-1 and SARS-2, or COVID-19. and also a number of respiratory viruses, including OC43, 229E, and one from Hong Kong. There are also a similar virus that causes horrible respiratory disease that is endemic in the Middle East right now, called MERS. So the common cold viruses, or the seasonal coronaviruses, as we call them, can cause up to 15% of all cold and flu-like symptoms every year. These are normally circulating in the human population, and we typically get reinfected with them every 5 years or so, which has the effect of boosting our immunity to prevent or limit severe disease. One of the seasonal coronaviruses emerged in the human populations in the late 1800s, and we think that the virus caused a major flu-like epidemic that killed approximately 1 million people worldwide over the course of a 2-year period before taking kind of a seasonal infection role. We think that repeat infection, starting as children with this virus called OC43, promotes immunity that prevents the virus from causing severe disease and high mortality, as it did when it first emerged. We think that if COVID acts similar to the other seasonal coronaviruses, that we predict that COVID, sadly, may also become a seasonal type virus infection. If this happens, then it might take years after multiple repeat infections for us to develop the immunity required to prevent the severe disease that we're seeing with COVID. We're hoping that vaccines that are currently in development will help jumpstart our immune response and prevent the severe disease, but they probably won't completely block infection. So it may be difficult for us to break the cycle of this virus actually becoming a seasonal type virus infection in the human population.
Thank you, Dr. Streblow. The seasonality of it that you mentioned is really important and something I want to ask Dr. Hansel about. As many of us at home are thinking about, when can we get back to schools or work in the office or have different types of social interactions? Would surveillance on PCR testing or antibody testing help us get back to what normal is faster?
That's a really important question, and I think a question we've been asked really quite a lot recently. When we think about surveillance testing, we think that if there is some way that we could test people frequently, meaning every day, every 3 to 5 days, maybe once a week, using the nasal swab or some other method that could be less invasive, that's what we think about with surveillance testing. There's a lot of viral biology that goes into how we think about surveillance testing. So we know that as the virus ramps up, there's a window in which people start shedding virus particles. And that's what we pick up currently with the PCR test. But there are a lot of problems as we think about surveillance and knowing what the virus does in this setting. So I'll start with a couple of problems, and then we can maybe talk about some solutions to them. So first of all, we know that when we do our PCR test, and this really applies to pretty much any test that you'll have in a laboratory, there's a lower limit of detection. So that means you need to have a certain amount of something for the test to be able to detect it. In this case, you need a certain number of virus particles for the test to be able to read out as being detected, or we don't use the term positive, we say detected in this setting. But that means that if you're early on in the course of infection, you could be negative one day, and then by the next day be actively shedding virus because you're starting to produce more viral particles. So that means any gap in testing, if you're not doing it day by day, means that there could be a risk that you could miss people who are infected. So the alternative approach that we've been discussing is whether or not we could test people every day. And that's a pretty daunting logistical challenge in a sense. So that means you need enough supplies to do this. You need to have enough people to take the test and catalog the tests. And you need to make sure that manufacturers can generate enough reagents and supplies. And when we think about 4 million people in the state of Oregon, if you want to test 4 million people every day, that's a lot of tests. And it's a lot of people who need to be available to help logistically manage that. Now, recently there's been talk about tests that maybe have some lower sensitivity, but that are really good at picking up the majority of patients who may be positive for COVID-19. At OHSU, our lab is actually working on some of these methods ourselves, and we could talk about that more in the Q&A session. I'll say this still has a little ways to go to be ready to use, but ultimately, if we could get to a cheap, fast, easy to use, maybe self-administered test that doesn't require a deep nasal swab, that would be terrific. That would be maybe the first step into getting into a surveillance type test that we could use. So I talked a little bit about testing, but we know that that's only one piece of the solution. And I know it'd be great to have a one-shot answer, but I did want to say still the most important thing we could do is to make sure we continue to wear masks, that we socially distance, and that we wash our hands. I recognize that there's fatigue with wearing masks. I'm even holding a mask myself right now. But it's so important that we maintain this sort of preventive measure in addition to ramping up testing and finding new testing methods to prevent viral spread. Finally, we need to make sure that we have good contact tracing. We know that once someone's infected, it's not just about isolating the one person, but it's about tracing and testing the people who are around them and making sure we detect others who are positive as well. Finally, I think what we're all hoping for, and potentially one of the best ways to get back to doing our quote normal life, is vaccines. And ultimately, if a vaccine is successful, that will go a long ways towards getting this pandemic at least a bit under control. At Q&A, I think we could talk more about where we think vaccines are going and how successful we think they'll be based on past experience. But really, until we're at the point that we have adequate testing, that we're all taking the right safety precautions, we have a vaccine in place, and we could really aggressively monitor this disease in real time, that's where we really need to get to reduce spread in the community.
Thank you. Dr. Streblow, given that COVID has emerged as a pandemic, do you think this could happen again with another virus, given your background in virology?
Yeah, unfortunately, yes. There are a number of viruses that have the capacity to directly spill over into the human population. In the past decade, we've seen this type of human introduction of other viruses, such as Ebola virus, Nipah, Zika, Chikungunya, and of course SARS-1 and SARS-2, and their related cousin MERS. There are other coronaviruses similar to COVID that naturally circulate in bats and rodents that have the ability to directly infect humans or infect other species that can impact their ability to cross over into humans and cause disease. Thus, it's critical that we are prepared for these viruses through increased capacity in detection and diagnostics. However, the current COVID outbreak also shows us that we need to develop vaccines and therapeutics that can block multiple virus family members, because you can't always predict which coronavirus is going to emerge. Therefore, it's important to have treatments that can intercept all of the beta coronaviruses that COVID belongs to. Being prepared is paramount to stopping pandemics, like the one we are currently experiencing, because they have such devastating consequences.
Thank you, Dr. Streblow. It sounds like you two have been quite busy, but it seems like you need to be even busier in preparing for what's might be coming. So Dr. Hansel, what do you think we need to do to prepare for an optimal future state to prevent something like COVID from happening again?
Yeah, I have to say that over the past several months, really thinking about what we've experienced with COVID-19 has also really prompted me to go back and think about what is it that we want to do with this microbiology effort that we started last summer? And what kind of program do we really want to build? So last year, as I mentioned, when we had these high-level meetings, we were really talking a lot about operations. We're talking about testing in a microbiology lab. And those are really important things to have. And you need to have those at any academic medical center. But I also think we have a much bigger mission to fulfill. Remember, I shared with you that I came to OHSU because I firmly believe, as the only academic medical center in the state, we're here to work on behalf of the citizens of the state and to make health better. And so, you know, as I reflect back on what I think we need to do with COVID-19, rather than just thinking in this narrow bandwidth about a clinical laboratory, I think we need to really consider an innovative, cutting-edge infectious diseases center that's there to meet the needs of all the citizens in the state of Oregon and, you know, establishes OHSU and the state of Oregon as a leading site and a leading center for infectious diseases research, for testing, and vaccine development. I think the importance of establishing an integrated, broad-reaching infectious diseases center at the cutting edge will help us in a practical sense prepare for the future. Now, as Dan mentioned, COVID-19 may not be the last pandemic we experience in our lifetime. And I think a better approach, rather than waiting for an infectious disease to come to us, how great would it be if we could have this cutting-edge infectious diseases center that's already analyzed viruses that may be coming down the pipe, is prepared to do testing, has taken the first steps in preventing and maybe even treating the disease? And I know now with COVID-19, we're thinking a lot about viruses, but viruses aren't the only pathogens out there. There's all sorts of dangerous changes we're seeing in bacteria, fungi, parasites, and I'll tell you, I don't think we're doing a good job at winning this battle. And I think rather than being passive and waiting for someone else to come up with the solution, we need to do it ourselves. We have the expertise here to do it. And so with that, I would love to have the opportunity to develop a world-class infectious diseases and microbiology program here at OHSU, where we think about all of these emerging pathogens. And then not only do we do research and testing, but we also need to think about how we take the knowledge that we gain and apply it in practical terms to help all of the citizens of Oregon and beyond. We need to think about social justice. We need to think about access to health care. We need to think what we could do for childhood health. We need to take a look at, you know, basic medical services and how do people gain access to these, not just when we have a pandemic, but all the time. We could be reducing comorbidities and reducing the impact of these viruses if they do get a foothold. So thinking about that, I imagine part of this program focuses also on the environment, ecological sciences, how to mitigate the impact of climate change locally and globally. And I really firmly believe we can set the example and that we can go from not having a microbiology lab to being a global leader. Just think, what we do here in Oregon can change what we think nationally and globally. And we can function as an independent organization that focuses on doing the right thing. since we have this opportunity to build a program from scratch, why not make it the best that we can imagine?
Thank you, Dr. Hansel, and what a wonderful future that would be. I'd like to thank both of you for your insightful perspective today. This concludes our moderated panel, but now I'd like to open our Q&A portion of the live virtual event. What questions do our viewers today have for Drs. Hansel and Streblow? As a reminder, you can participate during this live Q&A via the chat box to the right of your screen. And our chat box moderators are standing by now to assist. During the registration process, we received multiple questions, and I want to start with one of those. Dr. Hansel, how has the epidemic taught us to improve health communication, influence, or what I call translational research, not just translation, but upward and downward communication to the public?
Yeah, that's really a fantastic question from the audience. You know, I'll say it's really pointed out where we have room to do a lot better in our communication. I think one of the key elements that we've seen is that information is really coming out in real time. Just as I shared that example of when I found out the first case was here in Oregon, that was the same time our infectious diseases group heard about that and families in the community heard about that. I think it's also helped highlight a lot of the regulatory processes that the public is now hearing about related to testing, meaning FDA regulations, pathology regulations, how tests are conducted. And I think that it's also really helped put a spotlight sometimes on how even a single news article can change how we think about testing, meaning what's the hot testing topic now? And you know, is it really valid or not? And I think sometimes, you know, the news that comes out is great. I think sometimes there's a single news report that makes people think, oh, could we have something like an immunity passport that, you know, at this point we know is probably not the way we're going to use antibody testing. But I think it's really shifted the communication into real time. That being said, I think that there's a whole bunch of room for us to improve in how we communicate. I'll say, you know, I've spent some of my time working with local news stations to share our knowledge, but I still perceive gaps in the community, and I think we could do even better.
Thank you. The next question from the audience is, to what extent is spatial analysis based on latitude and longitude or census tract of infected people used in the analysis of COVID-19? And if it is used, how is that data available to the public?
Yeah, so I guess I'll jump in with that. So the Oregon does use this data quite a bit, and you could get both zip codes of where people have been infected, you could get testing sites, you could overlay those with census maps. In fact, one of the projects that I've been working on together with OSU and Clean Water Services is wastewater testing and testing sewage essentially for COVID-19, and then going back into communities and using that as a metric to really enhance community testing in some areas. There's a limit how far you could drill down because of patient privacy, so you wouldn't be able to narrow it down, for example, to a street or to an individual household. But if you're looking by zip code, there's a lot of data that you could get out there. The Oregon Health Authority has some of this on their website.
I would also say that we've been working with local and kind of county health authorities here in Oregon, Multnomah County especially, in order to try and improve tracking. And we've been doing a lot of sequencing of the virus strains and isolates that we're receiving from our patients at OHSU. And so we're able to kind of track them in real time, and we hope to improve our ability to track over time with improved sequencing and information from the viruses that we're getting.
Thank you. We talked a lot about testing, of course, and you've been able to scale from 250 tests per day to hopefully thousands per day now. How does that happen? Is that a function of more space or more staff time or more kits? How can we scale up, and what does that mean for our capacity moving forward to be able to test early and often to get back to normal?
Yeah, so when we first started, we had nothing. We were building it from scratch, essentially. And the assays that we could get were pretty much all manual. But we had ordered a lot of equipment. Luckily, the equipment started coming in to automate some of these processes around the beginning of April and through May. And that's really allowed us to kind of ramp up the testing and improve our turnaround time with the testing as well. As far as improving the ability to go out into the community, we're starting to develop additional assays that are more deployable that we could hopefully spread throughout other hospitals and other institutions like schools and things like that to do more testing, to make it widespread.
Thank you. The next question from the audience is, Dr. Hansel, you've talked a little bit about fatigue on the restrictions from the general public, and that's understandable, about having to wear a mask everywhere and all the time. And I'd like to think that we'll carry our new habits of washing our hands and not touching our face with us forever. But can you talk a little bit about how long do you think we'll need to carry masks with us everywhere we go?
Yeah, that's a tough question. I guess I'll back up first and say I think it's really important that we maintain some of the good habits that we've learned, as we carry on in future, for example, flu seasons. Because I think hand washing, for example, makes a really big difference. I think the mask question is an important one and a hypothetical one. Ultimately, until we have a lot of people in the community that do have some sort of immunity to this virus and have been exposed to it, I think we'll be wearing masks. Now, a lot of that depends on the vaccine production that I'm sure the audience has heard a lot about. There's a number of companies working on different vaccines that are out there. But essentially, we really do want the immunity to get up to a certain percentage of people. And that will help reduce the spread of the virus and, most importantly, protect those who are really at high risk of being infected and having bad outcomes. So if you ask me to put a date on it, I probably know better than to put an exact date. But I would like to see an effective vaccine out and working in the community. And then I think, we could probably put a more realistic timeline on something like that.
Thank you. It's probably smart to not put a date on it. Well, we'll stay with Dr. Hansel, but I also want to hear from Dr. Streblow on this one as well. You both described a really exciting preferred future for how we can get ahead of, or at least be very well prepared for the next pandemic as it affects humans. How does that future integrate basic science, clinical research, testing and therapeutics, and ultimately larger scale public health initiatives?
Yeah, well, it needs to incorporate all of that, and I think even go beyond that. We really, I would say, in the scientific community, maybe haven't done as good of a job as we could at engaging communities to participate with us as partners in developing these programs. So as I mentioned earlier, we talk about childhood health, we talk about access to health care, we talk about social justice, we talk about the environments in which we live. And so I think it goes beyond even those 4 items, to a much bigger picture of how, it's not just scientists, working on something and clinicians working on something. It's really all of us as a team together working together.
I think, from my perspective, this has really opened my eyes to the need to coalesce different research, public health groups together, diagnostics into one group that functions well. Without it functioning well, we're not going to be that well-oiled machine that can really move forward. And I think basic research has a big play in this. We can develop tools, we can develop vaccines and therapeutics to get ahead of these things, but that requires a lot of money and time and effort and focus. But I think we can do it, and I think this epidemic really highlights the need for us to function more as a group instead of individuals in this process.
Definitely. That integration is going to be crucial. Dr. Streblow, can you talk a little bit about how and why this disease has affected different segments of the population differently? It's well documented or reported that underlying health issues make it worse, and the disease has disproportionately affected people across race lines and across socioeconomic status. Can you tell us a little bit about that, and also about how it affects children and young adults and the older generation?
Mm-hmm. So we know that the virus seems to be affecting people of color in the US as well as around the world disproportionately, and those with socioeconomic disparities as well. It has to do with a lot of different factors. Part of it is healthcare, that we really need to ramp up the healthcare and be more prudent with getting diagnostics to those people and those in the community that are more susceptible to the disease, and also to just getting the virus and spreading it locally. Children can get infected, and the news now is that they're playing a bigger role than we thought in the spread of the virus and the continuation of keeping the virus in the community. So we need to get ahead of this, and I think that more robust testing in all communities will help get ahead of the virus, and hopefully we can fester it out a little bit.
Thank you. And we've had several questions that were pre-sent, but I want to get to the ones from the live chat. So we'll start with the first one, and whoever one of you wants to take it, that would be fine. But OHSU is known for rural access, and have you instituted any testing in rural areas? Why don't we start with Dr. Hansel and go to Dr. Streblow?
Yeah, that's a really important question. Again, it's something, as I mentioned, that we really need to be more proactive on. We know that several communities around the state of Oregon have really struggled with access to testing. There were some point of care machines that went out early on that, as I mentioned, received a lot of publicity. We know now that they may not be as sensitive as we would like. And so as our lab team has discussed this, we really feel a social responsibility in many ways to try to provide better testing. I think what I'll do is turn it back over to Dan to maybe talk a little bit more about some of the rapid tests, the saliva-based tests that we're thinking about bringing up.
Yeah, so as Donna mentioned, we're trying to develop saliva-based tests because nobody really wants to be have something shoved up their nose multiple times if we're going to do routine testing. And really, you can use a lower sensitive test if you do more routine testing. And so that's kind of where we're at now. We're trying to develop a number of different assays. We're evaluating them currently in the lab in order to develop an assay that would be deployable to rural communities along the coast, to Eastern Oregon, to other places in the state that wouldn't have direct access. We get contacted by places like Bend and other places that are seeing really long turnaround times in their testing in order for us to help them out. And we're really trying to take that seriously and develop new assays and new tests and evaluate the ones that are coming out that you see currently coming out online and things like that. We're hoping to develop things in the next few weeks that we can start to deploy at least locally, and then further that as resources become available.
Dr. Hansel, would you recommend that those who believe they were infected before the official pandemic notifications get an antibody test now?
I have to tell you, this may be the most frequently asked question that I get. The antibody test, and I mentioned some of the challenges earlier, I think we've moved past the point of having bad tests into having relatively good tests that are specific for COVID-19. The question is, how long do these antibodies last, and how do they relate to the severity of disease that you may have? And so some of the publications that are just starting to come out, like within the past few weeks, have shown that many patients actually have antibodies only 6 to 8 weeks. Now, of course, that's going to vary. There's going to be more studies. I'm sure that range will expand. But right now, we're not sure how long these antibodies last. And so if you were infected in March, I would say, sure, it's worth getting a test to see if you have the antibodies. But if that test is negative, that doesn't necessarily mean that you are not infected. I think we'll see, with the vaccine deployment coming up, if that generates a more robust response. But what we do know from other coronaviruses that are out there, your immunity to them tends to wax and wane, which is why we tend to get reinfected with them every year. The question is the severity a lot less? And there's a lot more to the immune response to this virus that we need to learn.
Thank you. Dr. Streblow, we have a practical question from somebody in the audience. That they reside in a senior living community, and they were told that they are not allowed to be gone for more than 3 hours, or they will be isolated for at least 5 days. Does this make medical sense, or is that overkill?
3 hours. I think, anytime you feel like you've been exposed, you need to quarantine yourself in order to prevent infecting other people, especially in an adult living center. My wife works in one, and we're well aware of the consequences of living in these situations, that a virus that can rapidly spread throughout them, and it can be quite devastating. So I think we need to take it seriously. But I think, we need to be cautious as we move forward with this virus.
And we'll stay with you, Dr. Streblow. Somebody responded to an answer that said underlying conditions is pretty broad. Which conditions have the highest COVID infection death rates?
Yeah, so it seems to be people with diabetes or overweight, those who are struggling with immunity, either due to cancer treatments or other immunosuppressive drugs, like people who have transplants. Those people tend to not be able to fight the virus off. But we've also seen that people with coagulation defects are also subject to kind of weird vascular diseases that are prominent. And I'm hoping that we can get a list of things that make people predisposed and really accurately define what it is that about those diseases that predispose them to the infection and severe disease.
Thank you. Dr. Hansel, are there other institutions that have the cutting-edge infectious disease center that you envision at OHSU? And what other infectious centers do you think would be good to use as a model, if they exist?
Yeah, that's a great question. I always, really think about what the CDC could potentially do, and I really use that as a model of where at least we should start. I mentioned earlier that it would be great to have an institution that's more independent. So we really focus on infectious diseases and public health. And worry a little bit less about some of the politics maybe that goes on behind the scenes. For sure, there's a number of regional centers on the West Coast that are good, but none of them I can think of would do anything quite as broad as what we're thinking about. Now, that being said, I really envision us as being able to partner with a number of academic institutions around the country and do so on more equal footing, and really in many ways help lead the effort to coordinate what we have going on nationally.
Lastly, and not to make light of the conversation, but are you two getting any sleep? It sounds like this is around-the-clock work, and you have set up a lab and increased testing dramatically over the last several months. How are you taking care of yourselves, and how are your teams taking care of yourselves? We'll start with Dr. Streblow.
March through July, we're pretty busy. I won't deny that. I have taken a little bit of time for myself and my staff. I make sure that they, when they ask for time off, that they get it. But we all take it seriously. We all know we need to be there for Oregon in order to try and curb this infection and disease.
Dr. Hansel, do you want to chime in on that?
Yeah. Well, I won't tell you what my Fitbit tells me, which really kind of was a call to action on my part. But similar to what Dan said, we worry about all these people who have volunteered their time to help in the lab, our faculty, our staff, our administrators, people in the community who have partnered with us. And so we're really proactive in trying to make sure that people get, respectable time off, that they can rest, that they get a break from thinking about COVID all the time, which for those of you who watch the news a lot, it really can be overwhelming when this is all you think about every day. And I'll say, on behalf of Dan, myself, the other lab leaders, we really try to take this seriously ourselves and try to disconnect a little because I think it's too much if you think about this all the time and all the deaths that are associated with it and all of the next steps that we need to do. So I think, even for the audience, it's important to take a break and take some time for yourselves not thinking about this.
Well, we're almost out of time, but you used the words next steps, which I think is important for our last question, which is you talked about philanthropy playing a big role in the setup of the lab in 7 days, and you borrowed some equipment and you pieced it all together. But what role does philanthropy play in the future you've described? And what does that look like?
Yeah, and thank you for whoever in the audience asked that question. This is something we've talked about a lot. Philanthropy really made the testing efforts we currently have in the state of Oregon through OHSU possible. There's no way we would be able to be up to the testing that we have now. And I think it's going to play a huge part in moving forward. As I mentioned, part of even getting a basic lab set up has been financial stressors at the hospital and the School of Medicine. And I think starting to think about a lab, starting to think about research programs associated, it's easily tens of millions. If you think about an independent organization that can really take the role as a global leader in helping, you're for sure talking, a lot more. I'd say sky's the limit. But this is something I feel so strongly and passionately about. So I do think philanthropy is a really big part of it. But I also think, hearing questions from the audience, having conversations with our communities, engaging and hearing ideas, because there's things we haven't thought about that are just going to be so powerful. And one of the risks we have in science and in medicine is always being in our own little bubbles. And I think this pandemic has really shown us we have to go beyond that, and we really have to engage. And so I really wanted to thank the audience for all of their questions. And I would like to keep this dialogue going because I think this is how we improve what we do.
Well, thank you both. I am personally very grateful, and I know the audience is very grateful for your time in answering these questions today. It is invaluable to have both of you and your teams in our community battling COVID-19 and the next pandemic. Hopefully it doesn't come, but when it does, we'll be ready. I would be remiss if I didn't take the opportunity to express immense gratitude to all of the people in our community who came together and donated. There was hundreds of folks who came together and donated to the COVID-19 Relief Fund at OHSU that not only supported the work of these two doctors and their teams, but also our frontline staff. So thank you for joining us today. I hope this was informative. Before we wrap up, I want to make sure that you have an opportunity to provide feedback in the chat on the left-hand side, right-hand side of the screen. There will be a link to a 3-minute feedback survey. We'd be very, very grateful if you could fill that out for us to let us know how to make these topics more relevant and these conversations better for all of us. And lastly, if you have questions that didn't get answered, please put them in the chat. If you have follow-up questions for our doctors or for anybody at the foundation, please put your name and contact information in the chat, and we'll make sure that somebody follows up with you right away. Well, thank you again very much. This concludes our webinar. Thank you again, and have a wonderful day.